Chat. So please make me co-host if I don't think I am. Yes, so now we start. The host has now muted everyone. The introduction slides, please. Thank you so much. My pleasure in welcoming you all to this 257th edition of Thursday Musings. Today we will be talking about a topic that is less discussed in OPD, maybe because of certain cultural limitations, but it is a very important thing. Talking about female orgasms, exploring obstacles, and implementing supportive interventions. So as we were just talking about, the everyone will be on the mute mode. The meeting will be recorded. This recording will be put on the YouTube channel. The participants are requested to post their questions in the chat box. This will be taken up to the presenter. Uh, Next slide, please. My pleasure in handing over the session to Professor Dr. Tofan Patisab. He's from Cuttack, chairman of this program. Sir, over to you.
Thank you, Dr. Ali. Thank you very much. I welcome all the participants to this musings. Next slide, please. And I also welcome the vibrant moderators of this program, Dr. Amrit Patajoshi, Dr. Alim Siddiqui, Dr. Bisal Chabra, and Dr. Shobit Garg. And next slide, please. Our chairperson, Dr. Preeti Arun, is professor and Department of Psychiatry of Government Medical College and Hospital, Chandigarh. Her areas of interest: child psychiatry, autism and disability, clinical experience of 39 years, almost 4 decades, more than 130 publications, 11 book chapters, co-editor of textbook of community psychiatry in India. She has received awards: Dr. Bakshi, Dr. A.K. Kalar, B.D. Meal, Dr. Jishi Borar Award from IPS Nacho, Dr. B.K. Burma Award by Indian Association of Social Psychiatry. Welcome, Dr. Preeti Arun. Next slide, please. I hereby welcome Dr. Nimphe Walecha, if I am correct in pronouncing, Joint Editor of Indian Fertility Society 2022-2024, ex-Web Editor of Indian Fertility Society 2020-2022, Web Editor and Joint Secretary of Fertility Preservation Society of India 2023-2024, ex-Treasurer of Fertility Preservation Society of India 2022-2023, Forum Coordinator of Delhi Gynecologist Forum, ex-Vice President Delhi Gynecological Forum, ex-member of Infertility Committee AOCD, special achievements: Silver Medal for presentation on post-ART pregnancy outcomes in annual conference of International Federation of Fertility Societies in 2007. Abul Kalam Azad Award for excellence in contribution to TGF. Was Associate Guideline Development Group member in the Making Guideline on Poor Ovarian Response by Indian Fertility Society. As a co-convener of the Special Interest Group on Poor Ovarian Response, was awarded the Best Special Interest Grouper in the session 2020 and 23. Have delivered over 200 lectures in various conferences, publications in journals and chapters in several books. Welcome, Dr. Alecha. Welcome,
Thank
Dr.
you so
Arun.
much.
And the meeting is over to your hands. Someone has to introduce the speaker, and both of you can introduce the topics. Welcome.
Dr. Preeti, you can go ahead. Dr. Preeti, should I carry
So
on?
thank you so
Yeah,
much.
sure.
Yeah, thank you so
Please.
much. First of all, I would like to congratulate this forum of Thursday Musings because it started in COVID time and it's continuing, and it's continuing very well and bringing about very good topics. And this time, very special speaker and the topic. So we have Dr. Anita Sham, who's from USA. She's an integrative psychiatrist, a sexual medicine specialist, clinical sexologist, sex coach, intimacy and relationship coach. She is NLP, hypnotherapy, spiritual and pranic healing practitioner. She's an educator, speaker, researcher, and mentor. She's also a volunteer and community enthusiast. And she has multiple awards and achievements. Out of those, she has been a university topper, She is India's first female clinical sexologist and sex coach since 2002. So, a long experience. India's first and only to become a certified surrogate partner therapist, again, more than 2 decades. Privileged to be India's first and only psychiatrist to write thesis on Hijra community, and she loves to work with LGBTQ group. She is author and co-author for medical textbooks. She's a national and international speaker. She has publications in national and international journals, and she's member and fellow of national and international organizations. We are very happy to have you with us, Dr. Anita. Welcome.
Dr. Timfe, would like to introduce the topic, or Dr. Preeti, if you want to talk about the topic also.
Okay. So it's a very, very interesting topic. As I said, I was very keen to attend it because it touches a very often overlooked actually aspect of female sexual health. Female orgasm is something I don't even think majority of females even realize or give importance to. So, and it is very important in achieving it, which can affect a relationship or self-esteem. So, really keen to hear from you. Please, let's begin the session.
I'm going to start screen sharing and of course then start talking. So
Ma'am, if you can bring the mic closer, let's see.
yes,
Better. Awesome.
lovely. And you all can see my screen.
Yes, ma'am.
Beautiful. So thank you everybody for giving me this opportunity to speak to speak on a topic which is not usually presented, not really talked about, and I'm so glad Dr. Rao reached out um, and thought I was capable of presenting this topic. So I thank the organizers of Thursday Musings and thank Dr. Rao for thinking about me, for giving me this opportunity and thinking that I was capable to present such an unique see and still such a complex topic. And I am grateful that I'll be able to share something which is very practical to you all. You all can take it to your clinical practice and you would be able to see immediate results. So our topic today is female orgasm, where we are going to explore what are the obstacles and what can we do to support our patients. This is me. Enough talk about me. Not somebody great, but yes, um, this is me, a little bit of myself. So our goal today is we're going to explore, understand what is female orgasm. We are going to learn about the orgasmic disorders in female and how we can help our patients. Our limitations today are that we're going to focus on only heterosexual couples. We are not going to talk about same-sex couples. So let's understand what is this orgasm all about and why there is so much a hoo-ha about orgasm or pleasure. Now, we all know that sex in general is just not something which is very physical act. It's an orchestra between so many functioning of our body. And basically, when we talk about sex, we also talk about the various hormones, talking about the adrenaline, norepinephrine, our physical capabilities to have sex is our dopamine. We also talk about the love hormone, which is the cuddling, loving, emotional hormone oxytocin, which is involved. And as a result of this whole orchestra, we experience something called as orgasm or pleasure, right?
Anita
Uh,
ma'am, there have been messages that audio is not very clear.
wow.
Can we do without
Some
the headphones, ma'am?
let's try, and then you can tell me. Okay.
If not, the audio is gone, ma'am. I think you have to on the mic there.
I don't know what's the problem, but how about now?
It is better, ma'am.
Now, now,
Again, it is to the original volume, ma'am.
Abhi,
Ma'am, same, ma'am. I think if you increase the volume, ma'am.
Yes, the volume is increased already. Now,
Yes,
for our
ma'am.
lives. If we want to know how to
okay, hold on.
reach our potential, if we want to know
Hold on. Okay,
how to
Yes, ma'am.
fulfill our
hold
dreams,
on. Let's see.
our astrological chart is a map.
Something else has started. Hold on.
Hey, Nicholas, I'm so excited to be.
Oh God. There you go. Is it better now?
Yes, ma'am.
There's an audio, ma'am, which we could hear very clearly. आपने कोई audio चलाया था अभी?
हाँ, तो पता नहीं वो कहाँ से चल पड़ा था, to be honest. So
Oh,
let's do this. Stop sharing, and then I'm going to start sharing. Okay. Okay.
ma'am, if you can use without the headphones and see if that will work better. Just unplug the. Sometimes that works better. Maybe your
Abhi, do you guys
better.
Yes, ma'am. It is better.
It is
beautiful.
better.
Let's do this. And I'm gonna get back to my screen of my Zoom and go to screen share. Okay. So now everybody can see the screen. Can everybody hear me clearly?
Yes. I think, and for people who can't, if you can use headphones or earphones, I think that'll be better.
Yeah, because I'm on full sound. But in case if people are not able to hear, please get back to me one more time. Maybe sometime exiting and coming back can help in the sound. But if what about Amrit and Dr. Vishal? Can you hear me?
I can hear you, ma'am. I'm using headphones anyway, so
Good.
earphones, sorry.
Let's
So yeah.
move on with why do we need this knowledge of hormones? Well, we all know when we're talking about interventions or treating our patients, we need to know which hormone is acting up and where we need to target our treatments. So many a times this knowledge also helps because we are going to treat our patients. So knowing about hormones is very, very crucial. Knowing about what is our pleasure points is very crucial. So let's understand what is the relationship between sexual response cycle, the relationship triangle, and also the biopsychosocial sexual and spiritual model. We're going to quickly brush over this because I want to teach you what you could do when a patient comes to you with orgasmic problem. So this is a small little video and you to come forward as a volunteer and tell me what did you learn from this video. Can anybody come up as a volunteer and tell me what did you just learn from this video?
So I think primarily this video was about that he had a very short period of act. Because I've seen the series. So it was before she could even realize something is happening, and the husband used to come.
Of course, but there's something very interesting which we need to learn since we are talking about sex and sexual medicine, sexology. When a patient comes to you with one problem, remember it's not just the partner's problem, it is also the client, the partner, and something is happening with this relationship. So we learn from this video particularly that this female is definitely not having orgasm, and she's not having orgasm because it's not because she doesn't want to have orgasm, it's because her partner has a sexual dysfunction. And also to bring to your notice, this partner doesn't really think about that my partner would want to have pleasure, would want to participate in this act, and that's why their relationship is also being affected. So this is a very beautiful relationship triangle which was taught to me by Dr. Gaddis, and we talk about that it's not just one person's problem. Whenever we are treating a patient with sexual dysfunction, we treat the patient, we treat the partner, and we also focus on treating the relationship. So this is a relationship triangle. Now, this is also, we've all heard about the female sexual response cycle, and we know the stages of desire, arousal, orgasm, and resolution. And depending on the satisfaction the female experiences, she is motivated to indulge into another sexual activity. And this also, this this entire sexual response cycle, which is by Dr. Basan, she talks about that not necessarily the stages have to follow each other. It is a cyclic model, and where a female can experience arousal because of a stimuli and then would be driven to a sexual drive or a libido. And then depending on the play which is happening between the arousal and the desire, one experiences orgasm, and then depending on the experience she has, the positive negative response, she is then motivated to now experience another sexual response, right? So very important to understand that it is not a linear model, it's a circular model. And that is important not only for the patient but also to our partner, and how this sexual response cycle affects the relationship. So the take home message for the sexual response cycle should be, our focus should be on pleasure satisfaction, not solely on orgasm, because that becomes a bonus of an activity. Sexual desire doesn't necessarily have to follow arousal. A female, with the help of a stimuli, love, emotion, can experience arousal, which can motivate her to have desire. And then the interplay. And there are a lot of factors which affect the relationship, and that can influence one's capability or motivation, willingness to experience sex. Pleasure based, the sexual response cycle is about pleasure, not about goal orientation, right? And we need to focus not just on orgasm or at the end point, but we need to focus on the entire journey two people are having when they are indulged into an intimate act. And we all have talked about and seen how the biopsychosocial model is all talked about, but people forget there are other aspects of a human which are very important, causing a lot of dynamics, a lot of we could say a lot of issues. And this is also important because when we are treating our patients, we need to focus on the spiritual belief, the religious belief, the cultural belief, and also if there are sexual, first experiences, negative experiences, sexual myth, sex education, lot of things. So that's why we need to focus on the biopsychosocial, the spiritual, and the sexual model. And when we bring all these three concepts together, we have this wholesome intervention, wholesome management, wholesome diagnosis, wholesome etiology. So this is the triangle which comes together, where whenever you talk to a patient, he comes with a problem. We look at the sexual response cycle. We focus on each individual's biopsychosocial, spiritual, and social model, and we also look at how this is affecting their relationship. So this is a very beautiful, the way this topic is explored and implement the intervention. So this is a nice model. If you can always carry, you would never miss a point that, hey, you know what? Maybe she doesn't want to indulge in sex, or she is not experiencing orgasm, is because her husband has a problem and they are also having a relationship issue. Similarly, we also try to focus on the various aspects. So this whole little module or algorithm is very important. So now, according to this large study, the orgasm rates with sexual activity, women experience less orgasm with male partners. Now, I'm not talking to experience more orgasm with female, but in general, this is what this research shares, that female experience better orgasm with maybe female partners, or female experience better orgasm not just with penetrative sex. There are other forms of sex where female experience orgasm. And what Mintz et al. Reported in a survey is of thousands of women, men and women, 64% of women versus 91% of men experience orgasm during sexual activity. Okay. And also 65% of heterosexual women reported having orgasm usually or always as compared to men who experience more orgasm. And of course, we know why, because we were just looking at this video, right? So another study, which was a sample of 1569 men and 1478 women, reported that women reported orgasm, that is 51 to 60% reported with assisted intercourse. And I'm going to talk more in detail. 31% to 40% reported orgasm with intercourse with clitoral stimulation, which was unspecified. Really, what type of clitoral stimulation was this? 21 to 30% reported orgasm with unassisted intercourse. So you see the highest intercourse, highest orgasm, how she has achieved as compared to the lowest percentile. So highest was with assisted intercourse, and the lowest was with just intercourse. There's nothing happening more. And men reported that their female partners experienced orgasm 61 to 70% with assisted intercourse, and 41 to 50% with unassisted intercourse. Again, you see the difference, right? Okay. Now, noted concurrent clitoral stimulation increases the likelihood of women experiencing orgasm in intercourse. Now, talking about orgasm. So we've heard about penetrative sex. We've all heard about the vaginal penile penetration, and most of the men think that women can achieve orgasm just by penetrative sex, whereas women can achieve orgasm by this whole different types of modules, which we're going to talk about, these whole different modes. And this whole beautiful body, the divine body of female has, is orgasmic. Leave aside just that vaginal penetration, right? So we have clitoral orgasm, we have vaginal, we have mixed, that is both clitoral and vaginal orgasm. You have this whole body which is orgasmic. We have anal orgasms, we have non-anal, cervical, and the G area stimulation. So women can achieve orgasm by from all these areas and much more. In fact, there are more than 11 areas where female can experience orgasm. Okay, leave aside just the penetration, because I know poor men, they suffer with so much of anxiety that, oh my god, I need to have erection, I need to have penetration, and all that thing. But this is a nice study, and if you get a chance, please do go through this study. And again, this is exactly what we talked about. Clitoral stimulation 49%, vaginal intercourse 28%, mixed 9%, and the whole body, the anal, cervical, non-genital, and the G areas. Now, let's not talk more on this because you all can read, but anything which affects the sexual response cycle can affect the orgasm, right? The ability for a female to achieve orgasm. So remember, when we talk about orgasm disorder, we need to also focus on the other phases of sexual response cycle, because that leads to orgasm. That leads to the ability of a female to now be motivated or be positively encouraged to enter into another sexual response. We all know about the DSM-5, that persistent or recurrent delay in or absence of or absolutely no orgasm is called orgasmic disorder. And we all know DSM-5 says 6 months affecting personal and interpersonal relationship is crucial for diagnosis, but that doesn't mean we code our patient and not treat our patient when they come with problems. There are different forms of orgasmic disorders. It could be lifelong or primary, or it could be acquired, secondary, or situational orgasm issues. Lifelong is female has never achieved orgasm, and 4% of women, and highest found in young female single women. Acquired, secondary, or situational orgasmic disorders are more common form of orgasmic disorders, right? That means the female has achieved orgasm, she's experienced pleasure, but due to some situation, due to some etiology, now she doesn't experience orgasm in the same form. Secondary or situational, trust me, situational can be such a crucial thing. I recently saw a patient who doesn't get orgasm when she is in her house because there's a lot of family, joint family. But every time she's outside on a vacation with her husband, she enjoys sex and she achieves orgasms. Factors, it could be psychological, relationship factors. We just talked about the triangle, how factors can be depending on the sexual response. Factors can be the bio, psycho, social, spiritual, structural, all that model, right? And it can be due to the partner, or it can be purely due to relationship. We have medical and the psychological causes depending on the age. When we see a female, we see all these fluctuations which happen right from when she is in as a young adolescent and as an adult, menopausal, premenopausal. So all these areas, all these age groups have different reasons why female can experience sexual dysfunction. And when we talk about orgasm, so different age group, but medical, psychological causes, situationals, and cultural causes can also be factors leading to orgasmic dysfunction. Contributing factors again can be psychological, neurological, medical, psychosocial, medications which this female is taking, right? Mental issues, depression, common causes. We have various neurological issues which can lead to orgasmic problem. Neurological issues can be, we all know, because we need the nervous system to experience this rush, this pleasure, this contraction, which is orgasm. So we have diabetes, we have multiple sclerosis, spinal cord injuries, back injuries. Trust me, even simple backache, right? Backache issues can lead to dysfunction in experiencing pleasure during sex. Psychosocial factors, relationship factors, social context, negative upbringing, emotional factors, lack of partner lives away, not experiencing sex all the time or multiple times. All those factors can lead to sexual dysfunction. And when we talk about orgasm, we should remember what is the desire made of. Are we just talking about the biological factor of desire? Because desire is much more. This is important because when we try to dig into the history and we are trying to help this patient and couple, we need to know what is that erotic script or the cognitive components which they carry. Do they have positive sex beliefs or they have negative sex beliefs? What are the values which they have been brought up with, the negative messages which has been many a time female come with all these negative notion. Sex is bad, it's painful, good girls don't have sex, you're going to bleed, you're going to rupture. All are these negative messages. Intimacy or motivation, is this female really emotionally connected with this partner? Is she interested in experiencing orgasm? Is intimacy or motivation? And also remember, when we talk about libido, we also need to know about desire discrepancy. Two people cannot have the same desire. So there's nothing wrong, but people forget that why my female partner is not willing to indulge in sex or does not experience orgasm, or why does she is always interested in having sex. So this is a desire discrepancy and many people do not really know about them. When we talk about the excitatory and the inhibitory processing, we just talked about how certain things can really inhibit somebody's desire, somebody's willingness to have sex, even to experience orgasm. Also, there could be some factors which can really excite this person. I'm going to give you an example of a patient. Like, she would never be interested in having sex, and this husband was like, why is she like this? He comes home drunk, he is abusive, he's smelly. These become adaptive negative responses, right? She's not interested. So when we change the chemistry, when we change the cognition, when we change the behavior, now she is willing because she does want to experience love. So this is a research which was done on desire discrepancy, why two people do not match, right? North south. So let's hear this beautiful video.
एक बात बताओ श्री,
here, this is a perfect example of desire discrepancy, or sometimes when men are not completely aware that female can also have desire. We females also want to experience orgasm. People all where females also want to indulge into the same intimate act the way they want to experience and indulge. So this is the tipping model by Dr. Michael Perlman, and this talks about how an imbalance between negative and positive factors can really affect somebody's ability to have desire, arousal, and also experience orgasm. In fact, this can be a multifactorial etiological factor affecting sexual functioning of an individual. Okay, so again, multiple medications which can affect desire, arousal, orgasm. And trust me, we are psychiatrists. One of our culprits are the SSRIs. So be very mindful of when you're prescribing SSRIs. But we have anti-androgens, we have other hormonal medications which can affect their the ability to have orgasm or sex. Here you go, barbiturates, benzodiazepine, SSRIs, tricyclic antidepressants, all can be culprits. So make sure you're asking the history in detail, and also be mindful when you are coming up with interventions. There are multiple medical conditions, we talked about them. But yes, we should also remember longer the duration of a relationship, greater the chances of sexual dissatisfaction, but the distress is also lower. So there is high dissatisfaction, but the distress is lower. And even the spontaneity of having sex or the sexual desire is lower, and low the excitatory response to sexual stimuli. So what do you need to do, and why do we need to have this knowledge is knowing these facts, we need to help our patient to build up good communication, to build up more sexual vocabulary, sexual script, and maintain a healthy sexual relationship, which is out of just penetration, increase the intimacy. So this information is very important. And we also need to learn about the various attachment styles. If the person has any traumas, if the traumas are related to this relationship, or traumas related to past relationship, traumas related to childhood. So information about abuses, physical, sexual, trauma, every aspect should be digged in when we talk about sexual dysfunction. Very commonly, right? Sex play power struggle is completely ignored. There is a concept in psychology where a female doesn't just want to indulge into sex because she wants to show her power to her spouse or her partner, that, hey, you know what, I control this. Narcissism, narcissist personality, B personality men, women, women tend to get into this power struggle where this is my territory, vagina is my territory, and I'm not going to give it to you because you just want to have sex, right? So sex play and sex power. But this is another video which I want you to look at, how even the basic power struggle, narcissism, can affect a female's ability to indulge into sexual activity. She's traumatized, she's sad, she's not willing to indulge, and here she's also suppressed. Especially this particular video talks about how she wants to work, she wants to have her own autonomy, she wants to have her own independence, but the husband is trying to crush her down, right? So please, whenever you talk, whenever you took, you're talking to a patient with sexual dysfunction, please do forget of all, please do remember about all these factors, etiological factors, which can be a cause, because there your interventions are going to matter. The way you formulate your treatment plan is going to matter. You're bringing in all these factors. So now, when we know that our patient has sexual dysfunction, we know the causes, we know the very psychological causes, biological causes, social, sexual, and spiritual causes. We want to treat our patient. And of course, there are two different types of treatment modalities. We have non-pharmacological and we have pharmacological. Okay. So the first foremost, whenever we talked about sex, intimacy, we talk about sex therapy, we need to talk about sex education knowledge. We need to increase communication and we need to fortify the relationship with love and affection. Basic sex education lacks in people. That's why talking about the anatomy, physiology, sexual response cycle, exploring bodies, self-exploration, masturbation technique, debunk all the myth should be the focus in your first intervention. Improving the communication, improving the relationship should also be a part of your intervention because everything fails if you do not tackle these things. So sex education, knowledge, communication, and relationship building. Beautiful video.
टॉकिंग टू यू क्या हुआ?
सेक्स सिर्फ बच्चा पैदा करने के लिए करते हैं।
शादी की है, फैमिली प्लानिंग तो करेंगे ना?
प्लानिंग कैसे? ऐसे मैकेनिकल सेक्स करते हैं।
What do you mean?
तुम्हें कैसे नहीं समझ आता दिवाकर? मुझे दुखता है। कांट यू सी?
तो मेरे साथ अब सेक्स भी पेनफुल हो गया।
हाँ, सेक्स टास्क नहीं है कि फिनिश किया और टास्क खत्म। थोड़ा तो प्यार करो दिवाकर।
Volunteer and tell me, what did you learn from this video? Because this is all what is sex therapy. Your entire treatment, this video really is about your entire treatment which you can give to your patient. You don't even need to go to any sexology school. So please, somebody needs to volunteer and tell me what all did you learn from this video.
Ma'am, we can look at the
Basically,
chat. Chat,
yeah.
में there are messages coming in chat now.
Can somebody read? Because this is a very, very important video. And I want you guys to carry this video for the rest of your life because you're not going to miss on anything if you start treating patients.
So Preetha
Somebody
is
has.
writing that it is important, the importance of two-way communication and empathy.
Right.
Also, the sex education for both genders and the right vocabulary.
Okay.
Patriarchal belief that husband is given and wife has to not seek.
Beautiful.
How one should respect other person's needs and desire.
Beautiful.
Being assertive. Foreplay is also very important. Sex starts with communication, touch, warmth, and so on, not just intercourse.
Lovely. So let's summarize what this female said. She's upset. Of course, she's not enjoying sex. She's not having orgasms. She says that sex is not just for childbirth. It's not for recreation, right?
Yes.
Yes. Reproduction. It should not be mechanical.
Yes.
Right? It is painful. So please understand, I have a problem. I'm not enjoying this because I'm suffering with pain. It's not a task. It should not be a mechanical task. Right?
Yes.
Please do some love, like connect with me, communicate with me, do some love, emotional connect with me. Please do some foreplay because my body needs to get charged up. I need to be aroused. I need to be having that desire. So please do some foreplay so this body gets charged up. Okay. Please understand, I have desires. I want to experience pleasure and just don't finish it and do tata bye bye. Because even after sex, I need to connect with you. That is called after play. So your entire bio, psycho, social, sexual, spiritual, everything comes here as an intervention. Beautiful. So remember, the goal for you as a physician who's doing sexology should be you want to increase you want to improve the quality of their life, relationship, sexual relationship. You want to create a sex positive couple who are open-minded to try and explore, focus on pleasure, experience pleasure. Your treatment plan should be client-centered. What does your client want? And how can you achieve those results? So they should be goal-oriented. If they want to experience orgasm, your treatment plan should be goal-oriented to increase the desire, arousal, and orgasm. And they should be able to see results that, oh my God, I'm seeing results. This doctor knows what he or she is doing. And for that, if in case this is not your specialization, we have various modules. We have the allow, implicit, and the MEEPS model, which helps you to basically formulate your intervention. You can have your diagnosis, you can create a treatment plan, and you can also do intervention. So we have allow, implicit, the MEEPS model. There are various treatment modalities, and trust me, leave aside leave aside just the pharmacological, but the non-pharmacological ways. So comprehensive treatment for situational and orgasmia. Okay, and this could be also when the female is experiencing very less or very minimum orgasm or absolutely no orgasm, but we have the orgasmic consistency training. We had the directed masturbation, couples sensate focus, and sometimes these two are done together, that is sensate focus along with directed masturbation. We have the various position, and that's why the cat position, the coital alignment technique, is very important for somebody to experience orgasm. The men stay longer, right? Female female really enjoy or really want to are motivated to have sex when they can see that men can last longer even after they have finished or they've reached orgasm. So men stay longer. Technique is to increase you have to help the men to have a better control, increase their timing. So that means the ladies who, the saying which is ladies come first, let her go first and then you can follow. So in this way, we all know women can experience multiple orgasm, but for her to be engaged into this sexual activity, she needs to have pleasure. She needs to experience pleasure. So if a man can do that, it is definitely a plus point. But let's move on to know what are these different terminologies. So this is for situational and orgasmia. So I'm going to tell you one of my experiences. My first case at Boston Medical Center, when I first went to the United States in 2004, we had this young couple who had come to us. Of course, this female patient was suffering from pain, but she had never experienced orgasm, because all what was in their mind was penetration. That is all sex all about, the penetrative penetration, and the female should be experiencing orgasm. And my director at that point of time, Dr. Ricardo Monari, said, unfortunately, females do not experience or do not have pleasurable sex with just penetration. There has to be some clitoral stimulation, because this is where the anatomy is. The clitoris is here and the opening is here. So if there is just a movement happening here and no touch, no stimulation happening here, she is not going to experience orgasm. Just to add, but treatment for secondary or situational orgasmic difficulty is focus on the roles of physical, psychological, and interpersonal factors, because it is secondary. She has experienced orgasm before. She experiences orgasm in certain situations. So we need to focus on the models. Start with sex education, encouraging the patients to couples to expand the sexual script. Directed masturbation is very, very important in this situation. Now, in what is directed masturbation is female learns how to bring herself to climax. Okay, with different position, touching, movement are always helpful. They can also use different types of accessories and also involve the partner and teach them what is the bridge maneuver. So bridge maneuver, as we move on, but let me give you a gist of what is bridge maneuver. The male partner stimulates the female to experience pleasure, and as when she is going to climax, they do a penetration. He does penetration to also experience. And while he or she continues to stimulate, she can experience orgasm along with penetrative act. Sensate focus along with directed masturbation is also a very good technique. The goal of teaching the couple to stop spectating and begin, sorry, and begin focus on the sensation and the exchange of feelings and emotion. So this is for secondary or situational orgasmic difficulty. Now in primary, right, when this female has never achieved orgasm, so you want this female to achieve orgasm, experience what orgasm is. So this is definitely should be done by her first. So she knows what she's looking for. Directed masturbation is the choice of technique. Then we have the bibliotherapy where she learns, she gets education, she learns with different books and videos which we just thought. Masturbation along with use of vibrators, wands, or accessories. This can also be done in clinical setting, especially if you're a gynac and you're allowed to touch patients. I'm sure we psychiatrists are not, but in clinical setting, if a rapport is built, there's a trust which is formed between the clinician and the client, then this can also be the directed masturbation technique can be done in the clinical setting where the physician can give her a nice roadmap, and with couple sessions happening at the clinic, she can experience orgasm in a clinical setting, like in a very closed environment. But directed masturbation for primary orgasm, and we also talked about secondary or situational orgasm, situational orgasmic dysfunction. So again, nutshell, we know we need to focus on the biopsychosocial, behavioral, and the biological causes to treat this problem. The mainstay of therapy should be sex therapy, psychotherapy, and a lot of marital and relationship therapy. Let's move on. Let's move on. Here, nice video.
She's young, but you know its importance.
We have different stages. Help the woman develop positive attitude towards her own body and genitals. This can be done by sexual or body mapping. Improve communication and sexual understanding. Okay, communion and communication. Sensate focus, we all know, which is designed by Master and Johnson, starting with just non-genital, sensual, loving exchange of touch, emotions, feeling, and move on to genital touching. We have cognitive behavioral therapy along with mindfulness technique, which is a combination of cognitive behavioral therapy and mindfulness techniques. Wonderful results have been seen. If you are somebody who is experienced or learned in this field, or we have various therapists who do that. Pelvic floor therapy is are various techniques which are done by physical therapy. This helps in mobility and relaxation of the pelvic floor muscles, increase the blood flow through the pelvic floor, increase the mobility, and female can experience better orgasms. Vaginal penetration, which, if she suffers from dryness, we can give her lubrications, we can teach her directed masturbation to enjoy, or also we can give her accessories. Okay, there are different positions which can be taught. There are different vaginal moisturizers which are water-based and can help in keeping the flora moist if there is dryness and causing pain. Sex toys and pleasure accessories. Now, this is another technique which is called the emotion focused couples therapy, where the focus is in building emotions and connection between the partners. And this is found to be more effective in treatment of women who suffer with low desire as compared to the mindfulness techniques, right? So this is emotion focused, not just using mind, but connecting emotion, building that relationship. Beautiful technique, guys. Beautiful techniques. And if you get a chance, explore this. This is called pleasure literacy. This is where you give women charge on understanding what is pleasure to them. So this is by the Global Advisory Board of Sexual Health and Well-being, and building up the pleasure literacy helps in women having autonomy and ownership of their own pleasure. This is by this includes being knowledgeable about potential ways of experiencing erotic pleasure, having the body awareness to be able to feel what is pleasurable at the moment and what is not. So I enjoy this. This is what is erotism to me. And I do not enjoy this at this point of time. It's called pleasure literacy, cause giving them a pleasure freedom. Beautiful technique. I know it's all words, but when you get a chance to read my slides, please go through them. Okay, we just talked about this. So let's move on. Now we have systematic desensitization. Female who have aversion to sex, yucky, dirty, and it's painful, phobia. We have beautiful technique called as systematic desensitization. You all know about this technique. We use it for our phobia patient, OCD patient, all sorts of patient, but it can also be used for patient with sexual dysfunctions, especially if they have no desire, they have no arousal, or even they do not have orgasm. What is leading to this dysfunction? Remember, anything which affects the sexual response cycle. And the treatment is systematic desensitization. Somebody, for example, this is just one of these examples. Somebody who just doesn't like kissing because there's exchange of breath, there's exchange of saliva. How you can gradually start, giving small tasks, patient kissing yourself, looking at kissing a paper, kissing something, you move on to get to go to partner kissing. Beautiful technique, right? This is, again, we talked about the directed or the guided masturbation, which is a cognitive behavioral mindfulness based technique where you use your mind, some behavioral technique to experience pleasure and be mindful of all the sensations, the sexual clues, the comfort, the sexual feelings, and use of vibrators and wands can also be encouraged. Again, directed or guided masturbation. Sensate focus, we all know about this technique, but if we're talking about orgasmic dysfunction, we can use sensate focus along with cognitive behavioral therapy techniques as well. This was designed by Master and Johnson's initially for men with sexual dysfunction, but now widely used for females, for couples. And I think there's a myth. I think people think this can only be done with partners, but there are different modifications to sensate focus where an individual can also do sensate focus to themselves to experience pleasure, to experience sensuality and sexuality. And also this can be then moved on to partners. So Master and Johnson's reduces anxiety, explore sensations, da, 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 da. Cognitive behavioral therapy can be used alone or it can be used in combination with pelvic perineal re-education. What does this mean? This is intended to modify maladaptive sexual scripts, some forms of sexual distortion. My vagina is too tight. Oh my God, I'm not ready. It's going to hurt. It's going to bleed. Da, da, da. It's going to break open. Sometimes it's like, oh my God, my organs are just going to fall off. So you try to give cognitive behavioral therapy and also you do perineal re-education. We have behavioral therapies. We just talked about sensate focus, but we also have various techniques which we can use. Behavioral approaches, which can be positive, which can be rewarding. And remember, rewarding approaches can be experience orgasm, experience pleasure, the positive responses. Sex education, right? And there's a nice, beautiful video which I'm going to show it to you. But sex education, oh my God, is so crucial. We basically start with just teaching them anatomy, physiology, talk about sexual response cycle, that this is what a female body wants. Men sometimes don't even know because it's never been taught, but we can use various types of modules to give sex education. We talked about bibliotherapy, where we give them books to read, homeworks are given, reading material to educate themselves, to increase their knowledge. Okay, nice technique, guys. And this is done in three formats, like three factor patterns. This was by Levet. So this is called the trifecta. So let's see what this is. So if a female comes to you and you have this, she suffers from sexual dysfunction or orgasmic dysfunction, you work in three patterns. you increase their orgasm. Orgasmic consistency treatment is given, relationship satisfaction is given, and sexual satisfaction. So these three come together to form an intervention module. Also, we focus on communication, attachment, and sexual harmony. So they all work in three factors to increase their motivation and ability to have sex. So a good romantic relationship and a good romantic sexual relationship is bidirectional, which may or may not be independent or dependent on orgasm consistency. Right? So remember, these three work together. So just not experiencing orgasm, relationship satisfaction, sexual satisfaction, improving communication, attachment, sexual harmony. So another technique, interestingly, I want to stop it and I want to tell you, you might be wondering, why am I talking about so many techniques? I want you to know something. Sometimes, I have my colleagues who come and say, "Hey, I'm not able to crack this case," and I always say, there's not just one technique to help your patient. Look at the various technique, the diverse techniques we have, and one thing is going to click, right? So this is another technique, which is a 4 element sequential model, and we can talk about this some other time. But another technique, which is increase the positive reinforcement, communication, resolution of the conflict skills. This is by Low Piccolo Friedman technique. Orgasm consistency training. Now, I want to talk a little bit more on this, but this is very important. Just sit back and remember something which you really like. How did you start liking it, and why do you continue to eat, or why do you continue to do that? Because you're enjoying it, you're having pleasure with it. It can be a small little piece of a chocolate, to a cold drink, to even enjoying company with somebody. You're experiencing pleasure, you're enjoying, and that is the concept of orgasm consistency training. So if for any reason you cannot think of, what do I need to do with this patient? Remember, as many times she enjoys, she's happy, she's experiencing pleasure, she's going to be motivated to indulge into that act. So if you can just focus on, how about you do something that she enjoys, she experiences pleasure, you will see the equation changes. So this is a very important technique. Even if you forget anything in what my presentation is, orgasm consistency training, you should remember, and that can be used even in your personal life. I'm enjoying, I want to do it more. I'm having pleasure, I want to do it more. This is fun, I want to do it more. So orgasm consistency training. Now, these are various positions which you can teach your patients, and they can enjoy sex, and they can really experience, female can achieve orgasm. So the first is the saucy spoon, where the penetration is happening from behind and still stimulation is happening. Remember, we talked about directed masturbation, stimulating, penetration. So we are talking about here penetration happening and at the same time stimulation. Miraculous missionary position. This is kind of like the cat position, which I'm going to talk to you about. But here, minimum penetration, but still stimulation is happening with the two beautiful body rubbing against each other. The 6 and 9 position, the women on top position, where she has a better control of the movement, where she has a better control of her orgasm, right? Danger free is for couples who have disabilities, pain, or some type of condition which hampers or restricts them to have normal sex. Cosmic chair position, again, two beautiful divine position, two different bodies coming together and experiencing contact. So here is very, very, very important technique, especially if we are talking about secondary or orgasmic dysfunction, or even with primary. Now, why? Remember, I just talked about a case, right? The anatomy. Here is the pleasure point, and the penetration is happening here. Mismatch. So this position is called the cat position, where there is coital realignment happening. So while the male partner on the top is penetrating, there is a minimal penetration. So it's not this position. I hope you all can see. This is not, but this is more closer, where while he makes this movement, he is rubbing on the clitoris. So clitoral stimulation is happening while penetration is taking place. So this is called coital alignment, alignment in a way that there is stimulation of the clitoris to experience pleasure. So now we can also combine the hand riding, where the female directs the male partner with her hand on top of the man, and while she experiences orgasm or displeasure, it is just the hand movement where she is directing the partner. So coital alignment technique is the sensual intercourse where the male is on the top. There's a right. This is riding high position, rocking, stimulating the clitoris. These are all various sexual accessories. These are vibrators. These are all different types of vibrators. This is an O-nut which is put on the penis, especially when females are experiencing pain. This is to reduce the penetration or the depth of intercourse. So this acts like a barrier, but we have different vibrators. We have wands. There is also a beautiful device which is called the clitoral suction, which gives an effect of oral stimulation. This is a beautiful rabbit which is placed on the clitoris, and this is held by the labia, and this vibrates the clitoris. This is a bullet. This can be used as a a cock ring around the penis, and this acts as a vibrator, or this can also be put on the finger, and the clitoral stimulation happens. uh, Physical fitness, very important, because we all know that once somebody is doing high paced aerobic cardio exercises, this upregulates the androgen and helps in female arousal and maintaining the vaginal health. So please encourage your patients to be physically fit, especially doing cardio exercises. Lifestyle modification, healthy lifestyle should be followed. Please follow hygienic measures. Keep your genitals clean, so there's no smell, no type of smells and other types of lubrication. Avoid using harsh soaps, vaginal washes, because they can over dry your vaginal flora, which can cause discomfort. We have pharmacological interventions. Estrogen, testosterone, they top the list. But nowadays we also have other type of medication. Flibanserin is here, gives promises, but I haven't really seen results. But simple vaginal moisturizers can play a very important role. We have flibanserin, we have brimonidine. None of them have really shown much effect. Even though if it is FDA approved, I haven't really seen much results, but this can be used. And if you guys want, you can read the slide. We have other medications, but this is what I have used. And this is a nice research which was done for females suffering from pain. But a use of tadalafil 2.5 to 5 milligrams along with L-arginine gel can really do miraculous effects. I have a patient who was on all sorts of psychotropic medications, suffering from bipolar disorder. And she says, ma'am, I have never experienced orgasm. And we put her on 2.5 milligrams of tadalafil 2 weeks, increased to 5 milligrams of tadalafil for another 3 to 5 weeks, and we gave her L-arginine gel to be applied on the clitoris 2 times a day. And you know what she comes up with? She says, ma'am, I've never experienced this in my life, even when my husband was alive. But now I can experience orgasm. So I'm like, should we now taper off your medications? What do you think? And she says, no, 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 no. I'm ready to taper off my psychotropics, but I'm not ready to come off these medication because of the experience. We have tibololon, but I haven't used it, but people have used it. Please focus on sexual health, not just penetrative sex. There are other forms of beautiful intimate acts which one can, one can explain or one can teach your couple patients. But there's so many different things to enjoy. To prevent issues with sexual desire, set aside time, guys. Give priority to intimacy. Couples should reserve one-on-one time. Leave aside the children, leave aside everything. But one-on time, intimate time, reserved time for sex, intimacy, couples should mentally be prepared to try and explore, right? Read different things, maintain, even if they are traveling, maintain intimacy, like sending love messages, talking over the phone sex, masturbation over the phone, all such beautiful things. But I'm going to leave you guys with this little bit of video. Okay. For your patient hearing, remember it's a connection between two people. And lastly, we're going to end this lovely thing.
एक साल में 116 बार मिस
Thank you for your patient hearing. And imagine, oh my God, you guys can do so much to help your patient. There's not just one technique, it's thousands, and hope you can help your patient. Thank you so much.
Thank you so much, ma'am. Wonderful listening to you. Uh, Over to chairpersons for their opening remarks. Then we take the questions from the chat box. Audience is requested to put questions in the chat box.
Thank you so much. It was really insightful, and it's a very, as I said, neglected topic for women's health. So we now understand, that how orgasmic difficulties are common, multifactorial, but they can be addressed effectively through a combination of education, counseling, medical intervention, and also support. I think there's a lot of support needed and the encouragement and non-judgmental encouragement. You understand? Because generally it's very difficult, and normally in our society, nobody encourage somebody even talking about it. I think females will also not approach, and so it's not a luxury. It's very important to understand that sexual well-being is not a luxury. It's an essential part of our health. And by opening up conversations and providing supports, I'm sure that general well-being, general life can for females can be improved. So thank you for making us understand, and we can take the question.
I think.
Yeah, Shobit and Nishal, can you take the question in the chat box?
Yeah, as of now, ma'am, all compliments to you, ma'am, for the fantastic talk you've given.
Ma'am, there is
Very
a
wonderful.
question.
Yeah.
Ma'am, wonderful talk, ma'am. That ma'am, does cultural and geographical differences have anything to do with the lack of awareness when it comes to sexual needs and desire?
Of course. In fact, there was a big research. I hope you all can hear me clearly.
Yeah.
Yes, ma'am.
Yes, we can.
So, there was a very interesting research done which talked about how various regions, especially various countries, have different types of social messages about sex, right? Especially if when we talk about virginity, we talk about multiparity. So all those things definitely have an impact, and geographical locations, because there are different cultural upbringings which happens, which affect even the overall functioning of sexual functioning of a person. Leave aside just orgasm, but the entire sexual functioning of that person is affected. Now, I have to emphasize one more thing, not just for female, even for men, right? Yeah, so there's this research was specifically done for the UAE countries. You guys should definitely, I haven't put that in my reads, but very, very important to know that. Even if I have to add some more things specifically, the cultural religious beliefs. If if you have a patient, right? If you have a patient who comes to you and has sexual problem, whether it's a man or a female, it's very important to dig into their religious belief. Uh, Two examples which I want to give to you. One is one patient who came to us with erectile dysfunction. Okay, and this person was an Islam follower, and what happened was he said, "Ma'am, I have to do namaz 5 times a day." I said, "Great, but then I don't know when can I have sex, and like I'm lacking. I'm started suffering with erectile dysfunction, which is like a secondary thing." And we started working with his time schedules, and the way we found out time, and we could treat this with just psychotherapy and with marital therapy, sex therapy, is we worked with his time schedule, and we found out times in his schedule where he was available, because he was a business owner. So he was available home, and what he said was, ma'am, we live in a joint family, so my wife has to finish doing the cooking and stuff, cleaning, and then she has to go for a shower. So we're like, so here we can do what we can do is, before she goes for shower, if you can have a private time with her, so you don't, in the morning, because of the namaz, you cannot have sex by 5 times a day. But we found a time gap. We found this small little gap, and now these patients are so happy, the couple, that they found a time when they can mutually have sex and enjoy time. Secondly, this is another patient, and that's why you need to go deeper into understanding your patient. So this is another couple who were not really enjoying sex, like around 50s now. Again, somebody who have very strict upbringing, very strict religious beliefs, and they not only had restrictions about self pleasure, but also about oral pleasures. And then we really went on to find different ways with sex therapy. And oh my God, this patient who was taking PDE5 inhibitors for a very long time, we were able to take him off, and both husband and wife have been beautifully enjoying a very intimate relationship. So, very good question. And please remember, go deeper. Social, geographical areas, cultural belief all affect sexual functioning.
Ma'am, a lot of interesting questions in the chat box, ma'am. And I think, ma'am, what are the effect of menopause and orgasm, ma'am?
In meanwhile, Dr. Arun, sorry, Dr. Arun cannot unmute herself. Dr. Ali, if you can help, make her the host. She's not co-host.
Okay.
Can I talk?
Yes, ma'am.
Yes. So certainly. Now I'm going to give you, but there's a but there. Okay, there's a but. Females who have been indulging into intimate acts or having regular sex experience less sexual dysfunction during menopause as compared to females or partners who have not been experiencing or not been indulging into regular intimacy. And I'm not talking only about penetrative sex, I'm talking about intimacy. Okay, so I'm going to tell you one thing. So after 40s, right, there's a myth in the mind that female, oh, their desires are gone down. But you will also find, even going back to your personal lives, right? Dr. Preeti is right in front of me. I have Dr. Valecha. So if you just reflect back without even answering, females start having increase in sexual desire from the age of 40, 41, 42 to up till 47, because there's decrease in inhibitions, right? And there's increase in testosterone level. So at this point of time, where other roles have kind of subsided, they have taken a setback, kids are grown up, and other roles have really, that demanding roles have gone. All of a sudden it's noticed, and a lot of research have come, why would females suddenly start having desire, and not only just plain desire, but want to have explorative desires. They want to experience and explore at this phase of time. And if at this time frame their desires are encouraged, they are experiencing pleasure, they experience less dysfunction with menopause. Now, said that, if there is a female who is suffering with sexual dysfunction, desire issues, arousal issues, orgasmic issues past menopause, we can do so many things. We just talked about, we can teach them different aspects of intimacy, different ways to have orgasms, accessories, use of estrogen, right? We can also have different types of physical, emotional, intellect, intimacy. Like, we educate them, what more, go out of the box, what can you do to still have that connect and still experience orgasms or pleasure.
Ma'am, you showed in your video that there are two contexts of couples at different ages. Interesting question, ma'am, in the chat box is that does orgasmic difficulties are relevant to the age gap between the couples also, ma'am?
Yes,
Any kind of a data to support?
absolutely, absolutely. So here, and that's a special, and I'm so glad whoever noticed that video. That's a very nice video. So here we talk about young couple. Think about, we're talking about two age group, young couple and the middle age group. So this is young couple where their hormones are at a peak. They want to explore and explore and experience. So if at this point of time, where if there's a relationship problem, because in that video, if you see, the husband doesn't care. All he cares is about just the act. And this female, probably she is not interested. She's never charged up. There's no foreplay. So our intervention for this type of couple will be, you want to help them with sensate focus. You want to help them to experience or experiment with different stuff. So here your therapy will be very different. Now comes to a couple which is middle age, probably this person has some medical problem, the female has some medical problem. You are not going to tell them, how about you start directed masturbation, how about you start doing this position. No, here the interventions are going to be different, where we are going to relearn the sexual vocabulary, we are going to relearn the sexual script, we are going to try different out of box intimacies. It's not all about penetration, because here comes the restriction, age, medical conditions. So you want to try different things with this set of couple, and you're going to try different things with this set of couple.
Ma'am, two questions on the similar lines, that importance of sexual education in the curriculum and also in MD curriculum, psychiatric curriculum, specifically to sensitize a lot of biases in context of maybe Indian psychiatry or globally, ma'am.
Yeah. Oh my God. Talk about the curriculum, right? I think IPS should really take charge and put sex education, more about sexual medicine in our curriculum.
IPS
There's so much
secretary
of
of
lack.
board.
So much of lack.
Secretary sir is listening. Okay,
Ma'am,
ma'am.
yes, ma'am. Audience are also interested in, ma'am. I think a lot of people are curious about the upper ceiling age of a couple having a healthy couple
Normal.
and sexual. So what is, ma'am,
My
your
God.
No age, no upper age, no? I don't
Good,
think so.
Vishal. That's lovely, Dr.
Yeah,
Jha. So I
yeah.
have a patient, okay? I have a patient who's 75. I'm like, this is an Indian couple. I have a patient who's 75-year-old, a Pandit, right? And I have a patient who's 95-year-old, still very sexually active. Now, said that, I'm not talking only about, vaginal, peno-vaginal sex. We're talking about the whole intimate, beautiful act. It's such a beautiful divine act between two couples, two people, right? So there's no, I want to put this, there's no expiry to sex. How about that?
Right, ma'am.
No
Right.
expiry.
Great, ma'am. And there are a couple of questions here by Dr. Pankaj. How do you differentiate between lifelong versus acquired orgasmic disorders in terms of approach and management?
We just had those slides, right?
Yeah,
Primary
yeah.
anorgasmia, right? We talked about directed masturbation,
Yes.
which is one of the key things. And then we start working with different therapies and marital therapy and psychosexual therapy. And then we have situational, or we have secondary anorgasmia. So there are different. So that's a beautiful slide. Go back to those slides. I think I'm going to give those slides to Amrit. Amrit, either Amrit or.
Yes, madam. You send it to me, madam. I'll do it. Thank
Please
you.
study the slides first.
I always give away my slides so you all can learn, because I did not have that opportunity to learn. So I'm going to give my slides.
I will learn, madam. I will learn.
Amrit, please.
And then the second question is, how do you address the unrealistic expectations shaped by media, pornography that influence both patients and their partners?
Yeah.
And third also you can add what strategies can clinicians use to normalize conversations about female sexuality and orgasm in conservative settings?
Conservative. So first question is about social media.
Yeah. Unrealistic from the media, how they glamorize, how they increase the expectations of the partners.
My God. Yes. So social media, thanks to the lovely education which we are getting, men and women come with such unrealistic expectations. Oh my God. And my God, the demands which women have been happening, women are having with men. I sometimes I feel really sorry for men. because they have come as learned Google gurus. They have expectation about the timing, the type of sex, and the type of pleasure they're going to have, because all what this is being seen. So as educators, we need to educate these people about first of all is a sexual response cycle, how really sex happens, and how whatever is shown on social media or in pornographies are not real, because they are rehearsed. They are all medicated, sometimes even drugged, to show that type of intensity. It doesn't happen in regular people. So a right education and right knowledge is very important. Now, said that, Dr. Chabra, since you were reading, I'm going to ask you a question.
Yes, ma'am.
Do you ever watch porn?
I have, ma'am. Yes.
Beautiful. No, the question is not, do you watch porn?
No.
So that's sad.
Yeah,
Because
probably.
we all as therapy should watch porn. Now the difference is, right? Recently I was having a discussion with a colleague, like, oh, no, I tell my patients to stop watching porn. No. You don't tell them to stop watching porn, because then they want to do it more. What do? You help them to understand what is the difference between hardcore porn as compared to the softer romantic porns. What can be a healthier choice? Right, so we all should encourage people to watch beautiful, sensual, romantic porn as compared to which is the unrealistic. So you need to redirect, right? Cognitive behavioral therapy, this is what we do to our patient, direct them. So that is
Ma'am,
what we should do with social media, not have them stop, because that's not happening. That is not happening. Thus, the sensorineural stimulation which constantly happens can be mellowed down, because we redirect them into sensuality, not into an act which is like, oh my God, harsh. Oh, please. Now, your second question was,
so next question was, how do you talk about this in the conservative setting? And let me add a spin to it. I see a lot of couples where one of the spouse is very active, high libido. Other spouse has low libido. And there's a lot. So you realize that after a couple of months of treating depression or anxiety, this is actually the baseline. This is the real problem. How do you deal there? How do you square the goals there, where one somebody is very high libido and somebody is very low libido, and says, I don't want to, others say, I want to, and that's creating friction. So that becomes again a conservative setting. A person may have come from a mindset that I don't want to do this was for procreation, I'm done, or I'm not interested. The other person says, I want to do it, otherwise I feel very restless. How do you manage that?
yeah. So the first thing is conservative couples, right? Now, here is an answer which is from one of my mentors. They are conservative because they have not been explored. They are not explored. They have never explored and explore. My God, am I tired? So we have to encourage them to explore, right? And more than that is they are conservative because they do not have the knowledge. As simple as, if you remember watching that video where it's all about penetration, there's no connection, there's no love. So when we talk about conservative couple, is they are conservative till the point that they haven't come to you and you have not given them that positive approach, the encouraging positive approach. So you start talking to them about, first of all, what are their, remember that first step, myths, debunk all the myths. So what do you think? Is sex all about penetration? Is it all because we want to have children? Is it a task? So you start debunking. Tuck, 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 tuck. And then once the debunking and clear, then you starting building up the foundation by giving them the knowledge and giving them the education, which starts with sexual response cycle, anatomy, physiology. How does a female body work? How does a man's body work? What are their different desires? What are the female desires? Right? A very, very important thing which people forget, and I'm sure you all have seen patients, right? You have seen patients who come and say, ma'am, I don't want to have sex in the night, but my wife always demands having sex in the night. And we also have at the same time, women
Morning.
come and complain, men only want to have sex in the morning,
Morning, yeah.
right? And I don't want to get up. So what do you think it is? What do you think?
I,
Yeah.
yeah, I think it depends on again the cycle of other people. Some people are very tired when they come home. Some people are more out in the morning, some are in the evening. Some are morning people, some are evening
Point.
people.
Not hitting the point. Dr. Chabra not hitting the point.
Okay. Anybody else wants to try? Maybe
Anybody
Amrit.
else wants to try? Amrit.
Amrit,
Amrit
on
is
mute, man.
retired now.
What?
Let Shobit try. Shobit tries a lot, madam.
Madam, I have one added
No,
question.
hold on, hold on. Somebody answered. Somebody just answered. Somebody just answered.
Because early morning erection is better.
There's another answer which just came.
Situational. Early morning peak of hormones in men. Hormonal diurnal variation.
Yes, yes. And also, since men and women are so different, women prefer to have sex when they are tired and they want to relax. That's how our body works, right? And men usually can only function, especially sexually, when they are relaxed, and that's when they get proper erection. So understanding these bodies are very important. So even when we are talking about conservative couples, all this knowledge is going to help, because they are going to be like, they don't know all these things and the conflicts happen. Now, the second question was about the desire discrepancy, right, Dr. Chabra?
Yes, ma'am.
My God, no two people can be same, right? So here is an example, and this I want you to carry this for the rest of your lives. So we have a patient, right? We have couples, and the couple says, one of them says, "Hey, let's go for Chinese food," right? Go for Chinese food, and the female or the man doesn't like. So one of the partners says, "But here we are trying to help this couple. We are trying to help this couple to build intimacy, to build connection, to build emotion. So what do? There are various strategies we use. One is, how about you just go with this person while he enjoys or she enjoys, you're just being a spectator, you're just being part of their pleasure. Okay? Secondly, while this person is enjoying and having pleasure, why don't you see if you can also be part of that pleasure by trying a little. And if that trying helps, maybe you would want to eat it again. Or how about you just try a new experience? Just have it. Maybe you'll start liking it. So now put these three contexts in sex. If a partner is interested, right, you can just be part of the pleasure. You can be there stimulating each other. Yeah. They I have to, but he or she can be part of the pleasure, right? While he's enjoying, maybe you can stimulate this partner to experience pleasure, part of the pleasure. Secondly is, while this person is really, wanting to have sex, if he or she starts stimulating you, you can build up desire, you can build up your arousal. Okay. Lastly, just do it phenomena, like the Nike phenomenon. Just do it. Maybe you will start liking it. So there are various techniques which you can use, especially in desire discrepancies. But everything revolves, especially when females are there, because men, it's a very physical act. With females, remember that orgasm consistency training. The more she enjoys, the more she has pleasure, the more she's interested and motivated.
Right, ma'am. So, ma'am, I think we should start winding up. We are already overshot our time, and you are also tired, and we've been speaking regular for more than 1.5 hours.
Somebody just came like, hey, you have to wrap up.
Yes, yes, ma'am. We didn't send that person, ma'am. Sorry. Okay, I think we asked Dr. Preeti ma'am and Dr. Nimfia to the closing remarks, and then we hand it over to, if answer is not there, then to Amrit. Preeti ma'am.
Many comments coming.
there are so many comments, Dr. Anita, that we could have extended this session by another hour, and still there would be even more comments. So that just shows that how much required this session was, and what a wonderful session it was. I mean, more than 100 people are still logged into this, even after an 1.5 hours time. So thank you so much. It was very nice. And I think everybody, one carry home message is that there are various techniques which can help the couple. And so I think that's what it is. Thank you so much. And Dr. Nipia.
Can I say something?
Yes,
Yeah.
ma'am.
There's a remark by Amrit Budani.
Dr. Amrit Budani. Amrit Budani. Yes, ma'am. Sir, he's a very senior
Budani,
psychiatrist.
you're absolutely right. And as I said, it is just the way the body functioning are. Certainly, the morning erection is not associated with desire because men in general can have physiological erection even without having desires. So you're absolutely right on that. But yes, if the way the body functioning work, men prefer to have sex in the morning, especially when they are relaxed, when they are getting better erections, and of course the desire then builds up. We talked about the sexual response cycle. But lovely remark was that, and I wanted to say that.
Nimke, ma'am. Thank you, ma'am. Nimke, Dr. Nimke.
Yeah. So I'd already put in few comments earlier that we should reiterate that orgasmic difficulties are common. And I think you have given very nice practical examples. There are a few questions on my mind also, but I'm sure, as there's been mentioned, that this discussion can be continued over the night also. So, but maybe probably if you have some area where people can post in their queries and maybe ma'am can answer later. So there'll not be lesser of unanswered questions. I don't know how the forum works. So it will really help people answer their queries also, and probably they can help their patients in clinical practice also. Somewhere we care where I also have few questions, and the others can post send their questions to you, and maybe we can get a few answers.
So, ma'am, I think we do repeat good speakers, ma'am. So if there's a lot of audience, we do keep repeating. Yes, ma'am. So we do that. Thank you, ma'am.
Thank you for the wonderful
Thank
talk.
you.
Thank
And
you so
Dr.
much.
Amrit.
Good night,
and,
everyone.
Ma'am, Dr. Amrit has to say
Amrit, over to you.
official.
Good night.
Just 1 second.
Thank you so much, Anita madam. It was lovely hearing you. Lovely meeting you after a long time, even if it is online. The way you spoke from communications to anything, but the best part was, whenever you ask somebody, do you watch porn? Everybody will tell we don't watch. Now people can proudly tell, yes, we watch porn, but not the types you think. Porn, the moment you tell porn, it means something else, madam. So we need to, reframe the words. So, so I think it carried the whole, spectrum from what all we can do. So thank you so much. Thank you, Dr. Preeti. Thank you, Dr. Nimfia. I think this topic was better late than never. So thank you to my dear friends also, Alim, Sobit, and Vishal. Tufan sir is not there, so good night. And we had a lot of people, and I think the recording of this episode, after we look at copyrights and the PPT, will be watched again and again and again. Thank you so much, and good night. Happy orgasms to everybody. Good night.
Happy orgasm. And Dr. Chabra, next time, proudly say, I do watch porn, but
Ma'am,
I'm not.
ma'am, you have made us nervous, ma'am. All the moderators, you could throw any question to us, and we were.
But so again, we'll talk
Happy
about
and
it
long
maybe.
orgasms and
Yeah.
multiple orgasms. Good
Right,
night.
ma'am.